Hello everyone, this is Sweehoney Vujjini. Today I'm going to talk about imaging and abdominal tuberculosis. So the reason why I chose this topic is because India alone accounts for nearly 1/3 of the global burden of tuberculosis. Although pulmonary tuberculosis is the most frequently encountered form, any organ system in the body can be affected. And extrapulmonary tuberculosis accounts for about 10 to 15% of cases. And radiological imaging plays a very important role in the diagnosis. Just a brief introduction. Tuberculosis is a granulomatous inflammation caused by Mycobacterium species like the Mycobacterium bovis, Mycobacterium tuberculous hominis, and atypical Mycobacterium like the Avium intracellular. Routes of GI infection include ingestion of sputum, hematogenous spread, and local spread from surrounding organs. Clinical spectrum, it is predominantly a disease of young adults of age 21 to 40 years. It can present as acute, chronic, or acute on chronic. The symptoms include diarrhea and malabsorption in the ulcerative form, recurrent subacute intestinal obstruction, and strictures type. Abdominal tuberculosis can present as tuberculous peritonitis, tuberculous lymphadenitis, gastrointestinal tuberculosis, and visceral tuberculosis. The imaging modalities used are radiographs, barium studies like the barium meal follow-through, barium enema, ultrasonography, CT, contrast-enhanced CT, CT enterography, and CT enteroclysis, MRI, MR enterography, and PET-CT. The first one is the tuberculous peritonitis. This can occur in three forms. First one is the wet one, which is the most common and can occur in about 90% of the cases. Fibrotic or fixed, this can occur in about 60% of cases, and I'm going to discuss about these two forms in my next slides. Dry or plastic in about 10% of cases. It is characterized by fibrous peritoneal reaction, dense adhesions, mesenteric thickening, and caseous nodules. So the first type is the wet tuberculous peritonitis, and ultrasonography here shows complex ascites with loculations and septae in perihepatic and pouch of Douglas. This is a contrast-enhanced CT showing ascites that is hyperattenuating relative to urine within the bladder. Next is the fibrotic type of tuberculous peritonitis. This is a CT with oral and IV contrast showing omental caking here with thickening of the underlying small bowel. This is an MRI image, T2 weighted image with fat suppression, showing omental and diffuse peritoneal thickening associated with bowel loops conglomerate occupying the pelvic cavity. Next is the sclerosing encapsulating peritonitis. It is also called as the abdominal cocoon. This is a rare cause of intestinal obstruction seen mostly in young adolescent girls. It can present as acute, subacute, or chronic intestinal obstruction. And signs and symptoms include abdominal distension, weight loss, and occasional mobile abdominal mass. This is a barium meal follow-through image showing clustering of small bowel loops in the center of the abdomen, which are constant in location. Next is the CT image, axial and coronal views, showing 3 mm thick membrane encasing the small bowel loops and forming a small sac-like structure. Next is the tuberculous lymphadenitis. These are the ultrasonographic images showing multiple enlarged hypoechoic mesenteric nodes with foci of small calcification. This is another image showing discrete or conglomerate masses with a thickened hyperechoic mesentery. These are the CT images. In the first image, we can see peripheral rim enhancement with low attenuation center indicating vascular inflammatory reaction. This is an image showing homogeneous enhancement. In the third image, we can see multiple mesenteric lymphadenopathy forming a conglomerate mass. The first one is the barium meal follow-through image showing displaced bowel loops with paucity in the central abdomen. The other two are MRI images. The first one is the T1 weighted image showing multiple mesenteric lymph nodes iso-intense. The second one is showing iso to mildly hyperintense lymph nodes. The differential diagnosis for tuberculous lymphadenitis include Whipple's disease, necrotic metastasis, MAC infection, cavitating mesenteric lymph node syndrome of celiac disease, and lymphoma. The next is the gastrointestinal tuberculosis. The most frequently involved region is the ileocecal region. The signs and symptoms include diarrhea, abdominal pain and distension, anorexia and weight loss, and doughy feel of the abdomen. Complications for this include obstruction, perforation, perianal fistula, enterolithiasis formation proximal to the stricture, and hemorrhage. We're going to talk about ileocecal tuberculosis. We're going to talk about this very much in detail because this is the most commonly involved region. So here we see different signs on barium meal follow through. The first one is the Fleschner sign. It looks just like the inverted umbrella sign. Wide patulous and gaping ileocecal valve is seen with narrowing of the adjacent terminal ileum. The second one is the Sterlin sign. Here we can see rapid emptying of cecum with passage of barium from terminal ileum to the ascending colon. This occurs due to irritable mucosa of cecum. The next one is the string sign. We can see persistently narrowed segment of intestine due to inflammation or stricture. This is an image of barium meal follow through again. We can see pulled up cecum. Cecum looks like it's conical, shrunken, retracted out of the iliac fossa due to fibrosis. The next one is the gooseneck deformity. There is loss of normal ileocecal angle and dilated terminal ileum, which appears as a suspended and hanging from a retracted shortened cecum. These are the ultrasonographic images. The first one is showing marked mural thickening of the ileocecal junction. In the second image, we can see the paracecal lymphadenopathy along with the hypoechoic mural thickening of the ileum and cecum. The next image of ultrasonography shows pulled up cecum in the subhepatic region. Next is the pseudo-kidney sign. It's a non-specific indicator of the bowel involvement. There is thickening of the bowel wall with mucosal surface seen opposed together in the center as echogenic stripe. This is a target sign, which shows hypoechoic ring with an echogenic center on transverse ultrasound image. Next is the CT images. The first one is showing mural thickening of terminal ileum and cecum with the enterolith. Next is the contrast enhanced CT showing thickening and enhancement of the medial cecal wall with thickening of the terminal ileum. The differential diagnosis for ileocecal tuberculosis include Crohn's disease, lymphoma, amoebiasis, and cecal carcinoma. Crohn's disease is very difficult to differentiate in early stages. These two are very similar. So here is where the radiological imaging plays a major role. So this is the table showing differences between the two ileocecal tuberculosis and Crohn's disease. I'm going to highlight a couple of major differences. The ileocecal tuberculosis shows discrete and transverse ulcers, whereas there are longitudinal ulcers seen in Crohn's disease. On barium study, we see Fleschner sign and cobblestone appearance in Crohn's disease. Also, we see asymmetric irregular wall thickening. Lack of stratification is seen in ileocecal tuberculosis, and omental and peritoneal thickening is seen in ileocecal tuberculosis, whereas we see circumferential bowel wall thickening, mural stratification, and creeping fat in Crohn's disease. So these are the images of CT enterography. We can see the differences here. The first one is for the ileocecal tuberculosis. We can see cross thickening of the ileocecal valve and thickening and contraction of cecum. And the second one, we can see terminal ileum is dilated. Now, these are the images for Crohn's disease. We can see wall thickening, stratification, and abnormal mucosal enhancement in two segments. And here we can see there's a long segment involved in the distal ileum, all suggesting active disease of Crohn's. So when is MRI a modality of choice? To avoid ionizing radiation, MRI is used in pediatric and pregnant patients, and also in patients allergic to IV iodinated contrast. So this is the MRI image showing, it's a T1 weighted fat suppressed image from MR enterography, showing thick and small bowel loops, and also partly necrotic mesenteric mass. So these are some more MRI images. The first one is the T2 weighted image, showing thickening of the ileocecal junction and cecum. So these are T1 weighted images. We can see multiple mesenteric, necrotic mesenteric nodes here. So as I've mentioned, ileocecal tuberculosis is the most commonly occurring one. So anywhere from the gut, that is from esophagus to the anorectum, is less commonly occurring form. So I'm just going to go over the radiological features. So in esophageal tuberculosis, we can see the esophagogram showing multiple areas of irregular ulceration in the mid-esophagus. So after 6 months of anti-tuberculous therapy, there was healing of ulcers. This is a barium swallow image of an old treated case of pulmonary tuberculosis, showing traction diverticulum in the upper thoracic esophagus and smooth stricture with pulsion diverticulum in the distal thoracic esophagus. This is a contrast enhanced CT with oral contrast, showing circumferential mural thickening in the mid-thoracic esophagus. This is a barium swallow showing esophageal stricture with ulceration and peri-esophageal leak, same as seen on CT. Next is the gastric tuberculosis. So the first one is the barium meal showing gastric outlet obstruction with antropyloric narrowing with mildly dilated jejunal loops. Here we can see the stomach is relatively non-distensible without hypersecretion, and denudement of the gastric mucosa is noted. And also we see ulceration on the lesser curvature and a fistulous tract is seen on the greater curvature. We can see multiple ulcerations and effacement of gastric mucosa here. Next is the duodenal tuberculosis. The first one is the barium meal follow-through image showing smooth stricture in the second part of the duodenum. This is a CT image which is done 1 month later showing diffuse circumferential mural thickening in D2 and D3. This is a barium study again, showing stricture in the third part of the duodenum with extrinsic lymph node impression. Another image showing a sharp cutoff at the third part of the duodenum, which is simulating superior mesenteric artery syndrome. Next is the contrast enhanced CT image showing extensive necrotic peripancreatic lymphadenopathy causing marked extrinsic compression. Barium study image showing widening of C loop of the duodenum. This is a double contrast barium meal showing multiple superficial ulcers in the duodenal loop. Next is the tuberculous enteritis. This is a barium meal follow-through image showing early tuberculosis with mucosal irregularity and speculation. Enteroclysis image showing multiple stricture segments with dilated small bowel loops. Another barium meal follow-through image showing fixed matted and dilated small bowel loops with mucosal thickening. This is a contrast enhanced CT showing gross circumferential wall thickening of the jejunum. And here also we can note mesenteric stranding and enlarged mesenteric nodes. Next is the colonic tuberculosis. This is the ultrasound image showing markedly thickened wall of cecum with hypervascularity. This is a double contrast barium enema showing stricture in the mid-transverse colon. This is another image of barium enema showing concentric stricture in the distal transverse colon and splenic flexure. We can see a fistulous tract is seen arising from the hepatic flexure. Here we can see mucosal irregularity, ulcers in the sigmoid colon, complicated by fistula formation in the distal sigmoid colon. This is a CT image showing markedly irregular parietal thickening, decreased luminal diameter, and densification of adjacent fat planes at the level of cecum. This is the most commonly affected region by tuberculosis, adjacent to the region of the ileocecal valve and ascending colon. Next is the anorectal tuberculosis. MRI images, first one is a T2 weighted image showing transpancreatic fistula. Next is the post-contrast T1 image showing transpancreatic fistula. Here we can see multiple small tracts in the perianal region. Fistula in anal tuberculosis. Next is the visceral tuberculosis. This mostly involves liver, spleen, and the pancreas. Most commonly occurring forms are the micronodular and the macronodular hepatosplenic tuberculosis. This is most commonly seen in miliary tuberculosis or disseminated pulmonary tuberculosis. And the most common finding is the hepatosplenomegaly. So this is the micronodular form of hepatosplenic tuberculosis. CT shows liver and spleen with small pinpoint hypodense lesions with ascites. In miliary tuberculosis, this is a contrast-enhanced CT showing splenomegaly and multiple low attenuation foci in a patient with miliary tuberculosis. This is a contrast-enhanced CT of spleen showing low attenuation foci, and also we can note the necrotic node between the portal vein and the IVC. This is the ultrasound of the spleen showing multiple small hyperechoic foci consistent with multiple calcified granulomas. Next is the macronodular hepatosplenic tuberculosis. This is an ultrasound image showing small irregular hypoechoic nodules in the liver. It's a case of disseminated COX. This is a CT image showing multiple hypodense nodules in the liver. Ultrasonography of the spleen also shows small hypoechoic nodules. The differential diagnosis for hepatosplenic tuberculosis include sarcoidosis, histoplasmosis, metastasis, hepatocellular carcinoma, Hodgkin's disease, parasitic diseases, fungal infections, and pyogenic or amoebic abscess. Pancreatic tuberculosis, this is also a very rare form. So the CT of pancreas shows small hypodense nodules. We can also see a speck of calcification here in the region of head and proximal body of pancreas. This is a contrast-enhanced axial CT showing focal hypoattenuating lesion in the pancreatic head. So what is the role of FDG PET-CT in tuberculosis? It is not specific for tuberculosis, but plays an important role in the evaluation of known or suspected TB cases. It can determine the disease activity, nature, extent of lesions, and also evaluates response to therapy. Its routine use is very limited because of high radiation dose and cost. So this is a case of a 42-year-old man with dysphagia. We can see the images of PET-CT. So when the endoscopy was done, it revealed mid-esophageal stricture, but FDG uptake showed increased uptake in the mid-esophagus and increased uptake in the supraclavicular nodes and the mediastinal nodes. So carcinoma of the esophagus was suspected, but when the biopsy was done from esophagus and supraclavicular lymph nodes, it revealed tuberculosis. This is another case of a 36-year-old man with generalized lymphadenopathy. This patient also showed increased uptake in the cecum with irregularly thickened walls. There was increased uptake in the supraclavicular and the abdominal lymph nodes. Disseminated carcinoma of the cecum was suspected, but when the colonoscopic biopsy was done, it revealed tuberculosis, and the patient responded well to anti-tuberculous therapy. Thank you.